Okay, we'll go ahead and call the meeting to order. Roll call. Marlene.
Here.
Cindy.
Here.
Jared is here. Robert.
Here.
Kim.
Here.
And do we have anyone on the deal there? Is Heather on? So Heather is not here and Joe is not here. We need to make a amendment to the agenda to add the audit report under financials. Under D. And I would look for a motion to approve the agenda as amended.
We approve the agenda as amended.
Second.
Looking for approval of board minutes for October 20. No, is that right? Oh, on the agenda. All in favor?
Aye.
Approval of board minutes. Is it all the way back to October 24th?
November 21st.
November 21st.
And I make a motion, we approve the November 21st, 2024 meeting minutes.
All in favor?
Aye.
Any visitors' comments?
No submissions?
Any board member comments? Committee reports, resource?
Jason, Joel, Phil, Jim, and myself attended. Overall, our financials look good, although we'd like to see some improvement in AR. Hospital use numbers remain strong. There wasn't much of a discussion about any impact from the federal grant freeze. And I am going to let Phil and Joel and Jason cover more financials in more detail. We've got audit and other things to go over.
Thank you, Cindy. CAH, do we have a report on that?
Joe let us know that he'd be reporting out in February for both he's on.
LTC?
I did not attend.
Infection control? That's Joe also? Okay. New facility. Were there any questions regarding the report written by Justin?
It's just so good to hear that things are proceeding faster than planned and below costs.
Thank you for that report, Justin.
Welcome.
Quality and infection prevention report. Are there any comments or questions regarding that report?
The only comment I will make is I think she mentions the community needs assessment, and Julie mentioned it on the radio today, and just want to put that plug out there again that we want people to respond, and the link is on the PMC website.
There was a quality report and then there's the infection report. Is by any other comments on those reports? Thank you, Rachel, for that report, and Stephanie. That brings us to executive summary already.
Right. Moving along, I know that we'll have some time for the audit and finance, so I'll keep it condensed. These are 2 months from December, January, or December, January, right? Biggest thing is thank you for your attending the work session. Thanks to Jason for being present as well for availability. I thought it was a good work session, and looking forward to legislative fly-in next week. in Juneau. I'll be attending with the AHA Group, Alaska Hospital and Healthcare Association. And if you haven't had a chance to review the workforce report, I highly recommend it and read it. Again, I'm really, happy to see our staff are in that statewide report. And so it really showcases Petersburg, our PMC. And then there's excellent information on the importance of local workforce there. Also echo the Justin and the team up the hill on putting the work building, and I know it's a lot of work, no pun intended, for the work building, but it's on time, under budget, which is really challenging to do in Alaska, and it's much less rural Alaska. So, and it's really coming along very well. I think it's, go back to my statement earlier this week. I think it's really important that we not only receive funding for a new facility, but now we have a proven work up there on a building, a structure, and the site. And it really, there's a lot of teamwork, a lot of, assistance with the assembly on getting the site and the rock pit, and then our subcontractors and the contractors and architect working together. So I feel like we have an amazing team up there, and it'd be excellent to get some more funding this year to keep the project moving. So really important. I'll echo also the community needs assessment. Please make sure that you fill that out. We need to hear from the community so we know, get a sense of the response and the needs. We actually operationalize things off of that. I mentioned that at the KFSK Live today. Spent some time talking about some of the things we used. MRI is one of them that came out of a community input. I'm excited about the bringing the rev cycle in-house. I mean, again, this is something that's been a constant struggle for many years, and really having the ability to take those controls in-house. I'm very excited about building that out and reducing those AR days and improving the efficiencies of that. That's going to be really important moving forward. Access to care. I also commend the clinic on a lot of work on their schedule and optimizing the physician schedule and working through improving access to primary care providers. And that's really doing, that project has been going really well. And I feel like that's improved quite a bit, and they've been able to maintain the volumes in the clinic and get those primary care visits readily available. And lastly, I'm working hard on getting a specialist. So we have had some conversations with orthopedic group out of Anchorage of trying to get Scope Clinic working with getting some services back online here. We have Dr. Cap here this week for optometry, and I'm looking to see about adding some additional ENT services in town too. So working through some more specialty options going forward. And that's all I got. Do you have any questions? I do want to add on, we did a logo upgrade, and I have some information I'm going to ask Julie. Julie was leading that project, informational. So it's in the packet here. Page 22 is where it starts. I'm going to ask Julie to just report out an update on that before we move forward.
Sure. This is Julie Walker. So we started working on this logo refresh project back in September. Cindy was on our work group. Thank you for your time helping with that. And we had PMC staff and managers working together on it. And we worked with a Alaska-based graphic design company called Element, as well as local artist Grace Wolf. So Grace actually designed the logo almost 25 years ago when she was in high school. Sorry, Grace, I'm saying that publicly, but I was in high school too with you. She won a contest, and that's been our logo ever since. So it was a really fun and exciting opportunity to work with her. She was really excited at the opportunity. She said, I've grown so much as an artist. It's so exciting to get the chance to update it. And Likewise, I think PMC has grown a lot in almost 25 years, and we were wanting our logo to reflect that growth and our professionalism. It also, the project aligns really well with the development of our new facility. So the process was included a staff survey, focus group, some revisions back and forth with the team. And some things that came out of those, the surveys and the focus groups was it was really, really important to the group that we maintained the compass. The compass was a guiding imagery, and the blues were calming. And so we chose to maintain both of those and modernize the compass that we had. Grace also brilliantly added in a local landmark in the middle of the Devil's Thumb, kind of symbolizing the connection to the community and the commitment to our community. So I thought that was a really, really nice touch and was very excited. It's kind of fun to see what goes into the creation of a logo. There's a lot of meaning behind logos, and it was really fun to see them bring everything that the staff said to life in an image. So we're currently working with managers to update documents and other things within the facility to be ready to launch the new logo in March. So you don't really realize how many logos you have everywhere until you start doing this. But we're looking for a launch in March, and it's been going really well. So I hope that you got a chance to look at it in the packet. I'm happy to answer any questions.
Were there any questions regarding that? Thank you for that. Any questions regarding Phil's report?
No questions, but just a comment. I just wanted to reiterate in our resource meeting how favorable all of our comments were about the contractor and how they've been with the public and with us. And I just wanted to state that publicly again. And we thank you.
Okay, moving on to financials. Either way, I don't care. Which one would you, audit report first? Okay.
I'll go ahead and introduce our auditor is Sean Johnson from DZA. They are a CPA firm out of Spokane, Washington. They specialize in rural critical access hospitals, FQHCs, and have an in-depth understanding of the industry that we're working in.
Thank you, Jason. Thank you, everybody, for having me. I'm going to present your annual audit report for your fiscal year just ended June 30, 2024. So there was 4 handouts in your packet, the financial statements and the independent audit report, and there's also a financial indicators report, and then there was 2 letters. I'll go through all of this relatively briefly. Typically, it takes me about 25-ish minutes or so to get through everything, but it'll be very high level, very brief. If you all have any questions throughout the presentation, please feel free to ask at any point in time in the presentation. I'll make this full screen. So I'm going to start with the audit report, which is on page 1. This is the largest of the handouts, where it says basic financial statements and independent auditor's report on the front. So our audit report on page 1 is where we report on your financial statements. We provide our opinion on your financial statements, which is our obligation as your auditor. The opinion that we have here is what we call an unmodified opinion. That means that the financial statements presented in this packet are fairly stated in all material respects. So it's a clean opinion. It's what you want us to be reported to you. The report also goes through the management's responsibility for the financial statements. So all of these financial statements are management's responsibility. However, our responsibility is to audit the financial statements and then provide you with the opinion on them. I'm going to now turn to page 5. This is where we have the first of your 3 financial statements. So this one's called the statement of net position. Sometimes informally, this is called the balance sheet. So this is where we present your assets, your liabilities, and your net position. This is a snapshot on the last day of your fiscal year of all your account balances, assets, and liabilities. This statement starts off with your assets being everything you own. It breaks it into 2 components. current and non-current. Current just means the assets are more liquid, either cash or collectible accounts receivable. And then non-current is the less collectible, or less liquid assets, and mostly consists of your capital assets. So you can see you've got your cash and cash equivalents, you got your patient accounts receivable at the top, your grants receivable, that was mostly related to the construction project. Under non-current assets, you've got a little bit of foundation assets, your capital assets being the biggest component. And you can see that increase from 8 million to 15.7. That's because of the construction of the new building and the construction in progress that's included in that capital assets. Because you participate in the state of Alaska public employee retirement system, there are some numbers on here that reflect your or the hospital's proportionate share of the state pension plan's balances. So that net other post-employment benefit asset, so that is related to like the health insurance and such for your retirees. And so that is a net asset, meaning that the state has more assets than they actually have obligations. So this is your portion of that. You also have some investments that are limited by you all as the board. So because they're limited, that's why they're shown as a non-current asset versus current. Deferred outflows of resources also relates to the participation in the Alaska PERS program. So you've got the pension plan and the other post-employment benefits of the deferred outflows of resources. On the next page is the liabilities, deferred inflows of resources and net position. So liabilities is everything you owe. The liabilities are also split between current and non-current. Current means you owe them in the next year. Non-current means you owe them after the next year. So we start off with your accounts payable. That's what you owed your vendors for operating expenses. You can see that did decrease from 23. It represented 65 days of operating expenses compared to 92 days of operating expenses. So it just means that you've been paying your vendors a little quicker in 2024 than you had in 2023. The capital accounts payable is specifically related to the construction project. So those are the invoices that were related to that. We split that out from operating accounts payable. Accrued payroll is what you owed your employees for outstanding payroll that had not yet been paid for the last pay period, plus related taxes. Accrued vacation, balance of all your employees' vacation accounts. Let's see, the third-party payer settlements is what you owed to Medicare, also a settlement with Premera, but it's offset by a disproportionate share receivable. So it's kind of a net number of three different things, but that net number is a net payable of $300,000. And then current maturities of lease and subscription liabilities. So you do have some leases for equipment, and then the subscription liabilities related to your Cerner system. And those are the payments due on those leases and subscription liabilities during the next year. Under non-current liabilities, we also have the lease and subscription liabilities. That's what you would then owe after the next year on those. And then the net pension liability, so related to your participation in the Alaska PERS, the pension component of that is overall underfunded. And so that's why it's a liability. And this represents the hospital's proportionate share of the overall state's underfunded pension liability. Deferred inflows of resources is related to the OPEB, or the other post-employment benefits portion of your participation in the Alaska PERS. Net pension or net position is what's left over when you subtract all of the liabilities and deferred inflows from assets and deferred outflows. We do split that into three categories. Net investment in capital assets is literally the balance of your capital assets minus any debt incurred to finance those. Then we've got the restricted amounts related to the foundation, and then everything else is unrestricted. On the next page is your statement of revenues, expenses, and changes in net position. So this is where your revenues and expenses are recorded on the accrual basis of accounting. And that just means that revenues are reported when they're earned, expenses are reported when they're incurred, not necessarily when cash changes hands. So the top portion of this page is your operating results. Operating revenues, you can see your net patient service revenue being the biggest component of that. Went from about 20 million to almost 22 million, or a 9% increase over 2023. That's the largest component of revenues. For expenses, the largest component is your employees, so their salaries and related benefits. Salaries represented 163 full-time equivalent employees compared to 171 in 2023, since it did decrease a little bit. You then list out all the other expenses that you incurred to operate the organization for the year. You can see your expenses were about the same as they were in 2023, a little bit lower, but for the most part, about equivalent. So if you look at that 9% increase in net patient revenue, your overall operating revenues increased 5%, but your expenses maintained at the same level as 2023. So that's a positive relationship. And so you can see that resulted in operating income of about $2.2 million compared to the 915 of operating income you had in 2023. So very positive year. The non-operating section down below consists of the investment income, interest expense, the foundation investment income and donations, and then their expenses. And then you see the capital grants towards the bottom, and that's related to the building project and that 8.4 million that you had incurred on that project that was paid to you related to the grants that you have to fund that. So your overall change in net position was a positive 11 million, which is when you add the capital grants to the non-operating revenues to the operating income. The next page is your cash flow statement. I'll go over this a little bit more high level. From operating activities, you generated a net positive cash flow of 684,000 compared to a net negative cash flow of 2.8 million in 23. From capital and related financing activities, you received the capital grants, but you're paying that out related to the construction. So overall, you generated positive cash flows of 212,000 compared to a negative million in the previous year. Investing activities is what you're earning investment income and reinvesting that back into investments. So that was pretty minimal. Overall, your change in cash was 948,000 to the positive compared to 1.1 million negative in 23. I'm going to skip that next page, just a reconciliation between the two statements. So now we get to the notes to the financial statements, which start on page 10. The notes are here primarily to describe to the reader of the financial statements information about your organization and also be able to understand the financial statements in better context. So the first half of this page talks about the reporting entity, who you are, the type of entity you are, your relationship with the borough, the type of services you provide to your patients. Then we get into a couple pages of accounting policies, and this is where you've chosen to account for transactions in certain ways, or in other instances you're required to account for transactions in certain ways. This just discloses all of that, how you account for those transactions. And then we have a lot of pages in here that are detail schedules for amounts in the financial statements, and then other disclosures that are either required or considered significant. So I'm going to skip through the vast majority of these, but I am going to pause briefly on page 20. Page 20 is your net patient service revenue footnote. I always like to just point this out just so that you can see where or which payer sources your revenue is coming from. So you can see that your Medicare population out of the total is about 9 million, Medicaid about 7 million, patients and then related to third-party payers or their insurance companies is about 6 million, and then less the charity care. So those are patients who qualify under your charity care policy, and then bad debt for patients where you've tried to collect, but for one reason or another have not been able to, and then you write that off as bad debt. Now I'm going to shift over to supplementary information that starts on page 38. I'm not going to go through this, but I just wanted to let you know why this is here. So because of your participation in the Alaska Public Employees Retirement System, you are required to report supplementary information, which is just information about your participation in the plan that goes back goes back for 10 years. So this is a 10-year rolling schedule, has information on your participation in the plan. There's 4 pages of supplementary information that are related to the participation in the Alaska PERS plan. Now we go into more of the compliance part of the audit. So on page 43, this is another audit report. This report is our report on your internal controls over financial reporting. in accordance with government auditing standards. And so this is where we look at your internal controls and any weaknesses that we identify that would be considered to be a material weakness or a significant deficiency, we report those to you as an audit finding. And what a material weakness means is that it's a breakdown in your internal controls that's material enough to cause a misstatement in your financial statements. Significant deficiency doesn't quite rise to that level, but still important to communicate. I am pleased to report that we don't have any findings that are material weaknesses or significant deficiencies. So this is also a clean and positive report. And on page 45 is the last of our audit reports. This one is specific to your compliance with the federal grant requirements related to the Treasury grant that you received that's for the construction project. Because even though it was passed through by the state, it is federally sourced. And so with that comes the compliance requirements that you're required to comply with as the terms and conditions of that grant. And it also requires us to audit those compliance requirements and provide an opinion that either you complied or you didn't comply. Our opinion is unmodified, meaning that you did comply in all material respects. So we have no findings related to the compliance with the grants. Essentially, you spent the money on what the intention of the money was for. On page 50 is what we call the schedule of expenditures of federal awards. So this shows your total federal grant expenditures for the fiscal year. So that Treasury fund is there on the bottom. It's that 4.4, almost 4.5 million. You also had some HHS money that was also related to the construction as well, that 3.7 kind of in the middle. But overall, you expended $8.7 million of federal money in the last fiscal year. Any questions on the financial statements? All right, next I'm going to move to the financial indicators. And what we've done here is we've taken your financial results and we've put it into some or a few graphs, so you can see how you have performed in the 2024 fiscal year compared to previous fiscal year, also compared to peer hospitals. The peer hospitals that we have, and we get this from Optum 360 is the source of this. All of it is 2023 data, which is the latest that's available. And the four categories that we have are all hospitals in the state of Alaska, all critical access hospitals in the Western United States, all hospitals less than 50 beds, and then all rural hospitals less than 90 million, which is their lowest category. So this first graph is what we call total margin. This is the overall change in net position, so your overall net income divided by total revenues. For 2024 is 33%. Now keep in mind that the vast majority of that was the capital grants. And so I actually think that the next graph, which is the operating margin, is a little bit more relevant to you. Because capital grants come when they come, and then once they're done, they're done. Operating margin shows your overall income from operations divided by your revenues. So you had a 10.1% positive operating margin. That's very, very good. And also you can see the trend from 23 to 24 is positive. We did break out the impact on your financial statements of your participation in the Alaska PERS plan for both pension and OPEB. Just so you could see if you had not participated in that, where you would have been. Because a lot of times the change in the net pension liability or the net OPEB asset, it can influence your financial statements in a way that it's really hard for you to control. So that's why we like to just break that out separately, so you can see what it would have been had you not been participating in that. But overall, you had a very positive total margin. Without the pension, it would still have been a positive 2.3%. So a good trend from the previous fiscal year. Next one is days cash on hand. All sources. So this shows you if you stopped collecting cash on the last day of your fiscal year, how long could you run the organization before you run out of cash? You're at 104 days. It was an improvement from 80 in 2023. We like to see this at about 100 or higher. Once you're above 100, it really just depends on what your goals are of an organization and the cash needs in order to meet those goals. And so definitely moving in the right direction on this graph as well, and it's also a healthy number. Your current ratio shows you how many times over you can pay your current liabilities, which are those that are due in the next year, with available current assets. That's with cash or collectible accounts receivable or other more liquid types of assets. You're at 1.4. We like to see this about 2 to 3. However, you all do have that $4 million investment portfolio that is designated by you. And if you did need additional cash, you could undesignate that. So while it does look lower than the peer hospitals because that investment portfolio is not considered a current asset unless you undesignated it, it does look a little lower than the peers, but it's actually it would be higher if that was undesignated. So I don't think that's of any concern that that's lower than the peer hospitals. The next one is capital equipment expenditures to equipment depreciation. This one is showing you how well are you keeping up with depreciation on your equipment as it's aging out. Are you replacing it as it's aging? An indicator of 100% on this graph would mean that you've replaced equipment at exactly the same rate it's depreciated. For the last 2 years, you have been below 100%. However, with the new building, there will be some new equipment in that building as well, including an MRI machine. And so once that building is placed into service, I fully expect this to shoot up into the hundreds of percent. And in any given year, we're not concerned that this number is below 100%. What we like to look at is longer periods of time, say 5-year periods. And as long as the 5-year average is over 100%, it means that you are replacing that equipment as it's aging out. Next one is long-term debts and net position. This is showing you how leveraged you are with long-term debt. And really, the only long-term debt you have are the lease and subscription liabilities. So that's considered, because there's a long-term commitment on those, it's considered long-term debt. The decrease is not really related to paying on those, even though you did pay on those, but it's more related to an increase in your net position, because you did have that big capital grant and it increased that net position, increased the denominator here, which is why the percentage here decreased. But you did make payments on those lease and subscription liabilities, and you also had a very significant net income, which caused that. Next one is your days in net patient accounts receivable, showing you on average how long it takes you to collect on your collectible accounts receivable. You can see you are a little lower than the peer hospitals. We like to see this in about the 60 or so day range. 67, I think, is a pretty healthy number. There might be some room for improvement on that, but it's pretty good, and you can see it's lower than the peer hospitals. The gross calculation, days in net patient accounts receivable, is here. There is a little bit of a negative trend on this, going from 81 to 91. You always want your gross days in accounts receivable to be a little bit higher than your net, just showing you that your allowance on your accounts receivable is conservative and is reflecting the estimated collectible accounts receivable. Contractual adjustments percentage shows you on average how much of your gross charges you're writing off because you have a contract with Medicare or Medicaid or commercial insurance companies. This one is mostly to do with payer mix, the decrease. You did have a decrease in Medicare and an increase in Medicaid, which did cause a lower contractual adjustable percentage. Bad debt percentage of revenue. So this is just showing you how much of your revenue you are writing off, because in theory you could collect from a patient, but for one reason or another, you're not able to. This one, you are lower than the peer hospitals. That negative amount in 2023 is related to some recoveries of bad debt that you had in 2023. But you are lower than the peer hospital, so that's good on bad debt. And the next one takes the bad debt and it also compares it to charity care. The charity care is those folks that apply and receive a discount through your charity care policy, and then the red is the bad debt. If your full-time equivalent employees went from 171 down to 163, like I mentioned previously. And we look at your net patient service revenue per full-time equivalent employee. We did see an increase there from about 118,000 to 134. This is kind of an indirect measure of productivity, so a positive trend there. Salaries and benefits per full-time equivalent employee. The first bar is the actual amount, and then the second bar excludes, if you were to exclude your participation in the Alaska Public Employee Retirement System, what it would have been. So you went from about 81,000 to 83,000. Any questions on any of those? All right, we have two letters. This remaining part of the presentation should be pretty quick. So the first letter is our management letter. So while I mentioned before there was no material weaknesses or significant deficiencies, we did identify two areas that we just wanted to bring to your attention. These do not rise to the level of an audit finding, which would be a material weakness or a significant deficiency, but it's still an area of improvement that we wanted to just make you aware of. Both of these relate to policies and procedures. So we identified that you have not implemented written policy and procedures for all of the key areas of the financial reporting process. You have good people in those positions. However, the duties, the policies, and the procedures should be documented, written down so that someone could follow in their footsteps, and ensure that all of the related controls are being performed when the financial statements are being prepared on a monthly basis. And then the second one is also related to policies and procedures, but this one is specifically related to federal awards because you are receiving significant federal grant funding. The federal government expects you to have policies and procedures related to tracking federal awards, expending federal awards, making sure that you're meeting all the compliance requirements. So we're just recommending that policies and procedures for both of those areas be implemented during the next fiscal year to help move you forward. The last part of the presentation is our auditor communication letter. This letter is required by auditing standards, and it's a bunch of information that's required for us to communicate to you as the governing board related to the audit. So it's a little, it kind of goes a little all over the place, but there's just high level summaries of each. So we'll start in the middle of the page. Middle of the page talks about accounting policies. There were not any new accounting policies adopted. There wasn't any required to be adopted in 2024. The bottom of the first page talks about accounting estimates. You do have estimates in your financial statements. The most significant estimates are the allowance on your accounts receivable, so what's owed to you by your patients and your third-party payers. You have to estimate the collectible portion of that. Third-party payer settlements, Medicare, Medicaid settlements are also estimated. The net pension and other post-employment benefits, so your participation in the Alaska PERS program, is also considered a significant accounting estimate. We do audit estimates heavier than other parts of financial statements because estimates are a more riskier area because they potentially could be subject to management bias. We didn't have any issues with any of the estimates. On the second page, talks about any difficulties we had. We had no difficulties in working with management throughout the audit. Did not have any disagreements with management. We didn't have any material audit adjustments either. So that second paragraph there is probably the most important paragraph on this page. And that means that we conducted the audit. We had no material audit adjustments. And that means that the financial statements that you all get on a monthly basis are reliable because we didn't come in and make a bunch of changes after the end of the year. So that's very good. Towards the bottom of the page, talks about consultations with any other auditors. I'm not aware of any, like where management's reaching out to other firms about issues if there were any disagreements with us. So no issues there. Any conversations we have with management are not any condition to us being retained because you all as governing board hire us as your auditors. The risk assessment process is then communicated there at the bottom. So we do conduct what we call a risk-based audit. So we audit areas of higher risk heavier than areas of lower risk. And so we are required to communicate with you what our risk assessment process was. So the areas of risk that we identified during the planning component of the audit. So these three bullets, we've got management override controls. We list that as a risk in every single audit we do. And that's because you, as an organization, you have a good internal control structure, but it still relies on people to perform the duties in the control system, and management could override those controls if they wanted to. So we always list that as a risk. And then the next two are specifically related to those accounting estimates, the patient accounts receivable, the third-party payer settlement. Those could be subject to management bias, and so that's why we list them as a risk. But we use this to develop additional audit procedures to make sure that there isn't any bias in any of the accounting estimates. So no issues there. Those were just the risks that we identified. And then on the last page talks about the supplementary information. So when I mentioned that there was those 4 pages of the 10-year schedules related to the Alaska PERS program, that is actually not audited. That's supplementary information that is just there for further analysis. So that piece is not audited. The last part where it talks about the schedule of expenditures of federal awards, that supplemental schedule that showed all the federal expenditures, that is audited. And so that's audited and compared to the financial statements. That concludes the presentation, and I'd be happy to entertain any questions you all have.
Questions for on the audit?
Very good, Steve.
Questions? Thank you. Okay. Financial.
Before I get into reviewing the December financials, I just wanted to take a moment and thank everybody in the organization. You know, an audit is, a review of our financial reporting, and it's equivalent to what the clinical side does in a survey, but it takes the whole organization. You know, the board, when auditors come in, they look at board meeting minutes for the entire year. So your participation in setting certain standards, expectations, things of that nature, have a lot to do with the success of an audit. What the department managers, administration does every single day when they make purchases and they're coding invoices and things of that nature and following our policies and procedures, that's a tremendous lift. That's, in terms of when he says, well, there's no material deficiency here, it's because we're following good practices within the organization for how we make our purchases, how we record things, and we have proof and support for all of those things. And, I'm always talking about how we have a wonderful team in the accounting finance department, and I include so many people in that, Jill and Matt and them who assist in getting us reports and making sure our accounting systems work and that things are flowing into the right accounts and things of that nature. We have Justin Wetzel, who we've adopted into our program, and him helping us with all the information we need for processing the grant on the construction program. He's been so helpful in all of those things, those pay applications. But it takes the whole organization. And so this is a very good audit that was reported. There's one opportunity for improvement, and we've already begun working on that. That's establishing a set of accounting and finance policies and procedures. So we have suggested a table of contents, and Sean review it. He added a couple of suggestions there. There's about 60 that deal with accounting. There's another 20 that deal with kind of finance and how to optimize financial performance. I have 30 of the 60 accounting policies and procedures in draft format. We've delivered 10 of those to administration, and we're working through those. Joel and Sarah and Phil and I making final edits on those, and then we'll get those into place. So we'll definitely have these policies and procedures in place here in the next couple of months, and we'll pass that one off in the coming audit. So we're excited about that. I think the most important thing to note here is last year, I arrived, it's coming on almost 2 years ago, in March, and it was a very scary time. We were using a lot of money out of our reserves, and the first goal was to really stabilize our financial performance and get that going in the right direction. And you can see from these audited financial statements that due to a variety of things, not only just stabilizing our financial performance, but also moving forward strategically with the construction of a new facility, all of that has gone very well. And I think the most important thing that I would emphasize here is, there's a lot of money here. It's a $30 million, $30 million construction project that's going on, $27 million in grants. There's just the money from the organization, and our auditors just gave a report that all of that is being handled in a way that is professional and appropriate, and that we're reporting that correctly to you as a board and to the organization, to the community. So that's an important confirmation of the integrity that the organization stands by. So thank you. Let me move forward into the financial statements. I'll try to go fairly briefly here. The year-to-date for the 6 months ended December in our fiscal year have gone fairly well in terms of patient volumes. We've seen our clinic has been very busy with 5,177 visits compared to the prior year, 4,727. So we talked about in the assembly meeting the other night. What we want to see is strong clinic visits followed by people getting preventative medicine, other tests, things of that nature being treated in an outpatient basis. Radiology procedures higher than the prior year as well by about 12%. Lab tests are up about just not quite a percentage point. Rehabilitative services are on the rebound with having a good team of, some of them are locum, but we have a full team in place. Home health visits have rebounded quite well, 25% from the prior year. And emergency department visits are down slightly. And we're glad to see this. You know, we certainly would rather see people avoid injury, accidents, illness, be treated in the clinic. And then acute, we've had a reasonably strong acute. It's up almost 10%, 9.4. The area that we have been very busy is in our swing bed services. This is where a patient has been admitted for 3 days in the hospital, and then they need to stay for an extended period of time for recovery before they can go back to a nursing home, assisted living, or to home. So it's been very busy, 676 days there compared to the prior year of 245. So that would otherwise indicate a refund to Medicare. Medicare pays us on a cost basis, not on a volume basis or a revenue basis. So when our revenues or volumes go up, but our costs remain the same, we would refund Medicare for that overpayment. But we'll watch and we'll see if that number comes back down. Typically, there can be busy times in our year, and then there can be lulls. And then by the end of the year, it comes back to normal, but we'll keep an eye on that. Like to see that you know, we're here for the community and able to provide that care, and that when they've had a significant event, they might have had that someplace else, and then they come back to home. And the swing bed program is really designed for people to rehabilitate in their home community, to have better success with that. And then the long-term care is down just a little bit from the prior year. There was a very high census at the beginning of the fiscal year, in the prior fiscal year. But we're not far off of that. And recently, the last 2 or 3 months, it certainly have been very busy on the long-term care unit, and anticipate that by the end of the year, we'll probably surpass what we saw in the previous year. So, okay, patient volumes. I'll just highlight, you know, a couple key things here. The gross patient revenues were $1.7 million above budget, and we're 20% above last year at the same point in time with regards to our gross revenues. Total operating revenues, after we take out for the contractual allowances and things of that nature, what we anticipate we may refund back to Medicare because of the cost report process, we're showing that our total operating revenues are about 9% higher than the prior year, and about 9% above budget year to date. Expenses are a little higher than we budgeted for, but this is due to the higher census, bringing in additional individuals to provide these services. And, you know, we have been paid more, and so it prevents us from having to repay as much back to Medicare. So our expenses are actually up 13% over the prior year and about 8% above budget. Year to date, we are recording a net income and operating income of $229,000 as compared to a budget of $107,000. And a prior year, about this time, we were sitting at $647,000, but different changes in our cost report actually changed that by the end of the year. Then, of course, you know, we get to the bottom and we're recording year to date $6,369,000, mostly for the construction project. So our net change in position, or change in net position, excuse me, $6,736,000. You know, you can basically look at these numbers, these are for 6 months. You can times them by 2 and see where we will be by the end of the year. Be fairly close in terms of all of those transactions. And just the last couple of things that just some projects and some things that we're working on. As was noted in the audit, as we've talked about in the in previous meetings, some of our biggest goals, number one is to reduce our accounts receivable. And so we did give notice back in December to the company that we were working with on our outsourced billing. We have hired staff. They have received their computers and they've begun their training. And here in February, they will begin doing the billing. And by the 1st of March, about the second week of March, we will discontinue with that billing company and we'll be responsible. And then for the next 4 to 6 months, we'll see a recovery occur as we work down those accounts that we feel haven't been properly addressed. So that's an important financial improvement that we're doing. Number 2 is adding a new program called the 340B program. And so we're waiting for a final number to arrive anytime the first week of February. And that program will turn on. It's a relationship between us and Rexall. It's a program where the manufacturers of different medications are required to sell that medication to us at a lower rate. And then it's distributed by Rexall and we receive a rebate in that program. It only impacts name brand medications. It doesn't impact generic medications, but it does provide resources for organizations such as ourselves, helps defray some of the uncompensated care that we experience from Medicaid and charity care and those types of things. That's why those programs exist. And we are looking into one final program with regards to the COVID programs. It's called the Employee Retention Tax Credit. See if we may qualify for 2021. We may qualify for the 3 quarters there. So we have retained a firm and are looking at the impacts that we experienced during that period of time. If we have incurred about a 10% impact, which we can show that our expenses were up by 10% during that period of time due to different mandates, due to agency staffing and things of that nature, then most likely we'll qualify and we'll keep you posted on what we discover there. It takes a very, very long time to receive those funds, year to 18 months. So it's nothing that's going to happen immediately, but it's a potential for helping us to recoup that last little bit. I mean, if you recall back, we've shared some reports. What was the impact to our savings due to COVID? And we were still down about 1.4 million. And we hope to, between reductions in days in AR and the ERC, be able to replenish that and get our savings back up to where we'd like to see. And that kind of addresses the things that Sean talked about today. Can we get accounts receivable down? Can we get our days cash on hand up? And we'd be sitting in a very nice position compared to our peers. So that's what I have. Were there any other questions on the financials?
Just have one on that tax credit. Does that have any impact on the Medicare reimbursables?
No, it actually does not. You know, the Medicare is a cost-based program, so they look at our costs, and that program is it's more like a grant, and so it's not required to be to reduce our costs, and so it won't cause us to reduce our cost-based reimbursement. And a related one is the 340B. That one also is independent of the Medicare and the Medicaid cost-based reimbursement.
As we change billing to in-house, is it going to require a lot of negotiation with every single insurance entity that pays for part of the bills?
No, the insurance companies, we hold those contracts directly, like with Blue Cross Blue Shield or Aetna, MODA. We entered into a contract with them this past year. So those are between us. The billing company was only hired to provide staffing and technical support to assist in sending the bill to the insurance and then collecting that. They weren't involved in any of the negotiations or or tied into that process. When we set up, when Jill set up, and very brilliant, her and her team and the whole organization, they didn't otherwise, we did it with all of the stuff that we have in-house with Cerner and with our clearinghouse and things of that nature. So when we sat down and looked at the feasibility of, hey, what do we have to do to disconnect from HRG? Are there softwares or other things that we need to purchase or put in place to be able to bring this back in-house? And there's nothing. The only thing that we found here is we need to give some access to the person who will do the billing for Medicare so that they can get online to the Medicare portal. But it's not a big effort at all. It's not a software system. It's just a login and access ID. So kudos to them for making sure that we didn't hand over and get into a situation where we're obligated to that company. We maintained, said, we're going to do it on our system and you're just going to provide the employees.
You look at any of the reasons for we outsourced the billing. Several years ago, we went from internal to external. And did we look at any of the issues, why we switched to make sure we could, not get back in the same point, the same position?
We did. Jill and I had several conversations, talked to other people who understand the long-term history of the organization and our billing and what were the strengths and weaknesses of that. The weakness that we felt is that there aren't a lot of people here in Petersburg that have a lot of experience in billing. And so in bringing it in-house, we are working on a remote model. So we will employ 3 or 4 people to assist us in sending those claims out and following up and getting them paid. But it allows us to tap into people who have expertise, live across the United States and can do that work. We looked very closely. We have different things in place to be able to see when they log in, when they're working on accounts, how many clicks they make through the day so we can ensure that people are working on things. So very well, have a strong dashboard to ensure all those things are in place. But when we began advertising, we did receive several applicants, a lot of interest, and individuals with great experience. And that's where we feel that in previous years, it was, we would hire somebody, no experience, we train them, and then, maybe they'd move on to another job. We'd lose that investment. But we feel that by having a partially remote program, we'll be able to do that. We do have individuals who will be working on the self-pay, following up with patients on their balances, some folks in the community who will actually help us with billing for our long-term care and our home health. So we did identify people here in the community that have that experience that are already working for the hospital, and they're taking on those responsibilities. We just needed assistance in the billing and follow-up of insurance and Medicare, Medicaid balances.
Yeah, and if you don't mind, I just add to, we had contracted with a company earlier on. We switched to a new electronic health record. So then we had those issues, and then we switched over to another, third-party contractor in the effort to improve it, which went for a little bit, and then we're having the same issues. So now we're pivoting and shifting, and Jason's got a lot of background in doing some of these processes, so we're moving that in-house, and it's a big project, and it's a high priority in improving the AR days within our facility. So real excited about doing that. But PMC has done it that way in a distant past, so it's not like it hasn't done it. It's just,
Questions? Okay, we'll go ahead and move on to home health. Were there any questions regarding Laura's report on home health? Yes, ma'am.
I'm so happy to see it's fully staffed and all the staff is permanent.
I think all of us can agree to that.
Any other comments, questions? Thank you for that report, Laura. Human resources. Yeah. Were there any questions or comments on that report?
No question.
Yes,
What you have, some of them you have termed as behind the names for the positions.
Cindy Newman. So term just means, so this was a recap for the whole year. So though we may have had, for example, private contractors, we had total of 7, we had people come and go. And, or whether they were travelers or, I just wanted you to realize that there's quite a volume that goes through what, all of the orientation and all of the things that take place. And though they're not here, they were here. So. But it was a good year. We've learned a lot. I think we're getting better at using Paylocity to the better extent of it. I'm pleased with it, whether it's the onboarding, the evaluations, the surveys, we're learning about the surveys. It has a lot of uses. Sometimes I do get upset at it or frustrated, but it is going well. And I even recommended it to someone that Jason had asked about. I will say that having been in the position for so long is a plus, but it can also, like some of my things where, oh, I want this code to be the exact same from the other one. I should have went with the Paylocity code, but I didn't realize that at the time. So I'm an older person, and sometimes something that's new, I just need to believe that it's going to work versus going, oh crap, this isn't going to work. But it's going better. I would say that if you know of any cars that are available, if you could let me or Scott Zeifel know to buy. Not for us personally, but for the hospital. We are looking for cars.
have we looked at the return on the used cars versus buying something newer?
Jason is working with us on that, and we are thinking about that. We're thinking about a lease. So years ago, when we started the UW medical student, they were very kind and actually had us lease a Subaru. We still have it. And when the lease came up, we bought it. Well, and so it's been, it was our only new car we've ever had. It was very exciting for me. But anyway, so it is kind of interesting. So we've talked about different things, like should we keep these old cars that we're working on, for example, like the red CRV. We just got a belt fixed, and I'm not a mechanical person, but thank goodness Scott is. And, but then it went out again. So now it's back at Nordic Automotive. And so there's pros and cons but we're working on it because I know we've wanted to talk to Jason about it. I've talked to Joel about it just because it's a difficult thing when you don't have enough vehicles and they break down.
What's the average turnover on them? Or do you have one, an average?
I don't know if we necessarily have an average one. I will tell you that the red CRV that's in 1999 was bought by John Bringhurst when he was the CEO, and John's a while ago. And he started actually in, I think, 98, and the car actually happened to be a 99. It wasn't brand new, but so they do last a long time. Hondas, Subarus, not that I'm making, Toyotas, not that I'm making an advertisement or whatever. They do last a long time, but we use them till they're dead. Kim's like, yep, I know.
Comments or questions?
A wish for the future. In many ways, nursing through UAA is working really hard at increasing the pool. I wish statewide, obviously, the need for rehab people is so critical. Reading through the HHA report, we're not the only ones in this boat, but that seems to be a real problem area. So all the young people out there, think about becoming physical therapists and occupational therapists and speech therapists. We need them.
Just wanted to tag on to that, if you'll let me, just one more comment. So the auditor spoke about the importance of reinvesting into the organization and purchasing equipment, and the statistic he showed about, what is our pattern of covering depreciation by buying new equipment. And one of the most important reports was the first report that he talked about. It's a statement of net position. And I've been working on the financial analysis, the pro forma for the certificate of need for the MRI. And it really kind of highlighted something. So if we go back to 2019, just before COVID, and we look at our statement of net position, it was $300,000. Now, statement of net position is best described as, if you look at your home and you say, well, what kind of equity do I have in my home? How much, if I pay off all my liabilities and I were to sell my house, how much would I walk away with? And that's kind of the same thing when you look at a statement of net position. So in 2019, our organization, if we'd have done that at that point, we'd have walked away with $300,000. Not much, because all of our assets are fully depreciated and there's not much value there. And because of it, we didn't have any depreciation going through our cost report. As we, arrive at this point where we have built a new building based upon a grant, so we received almost $30 million in equity coming into the organization, not associated with the loan of any nature. You can add that to the $300,000. Basically, our equity has gone up to $30 million. And you'll see that over time as we finish the construction project and we get next year's audit, you'll see our statement of net position, what is the value of our organization, has gone up significantly. And that's so important.
Any other questions for Cindy? Thank you, Cindy, for that report. Moving on down to next meeting. Looks like February 27th.
Can I make offer a suggestion? I believe to make it a little more consistent with, I know that it was the third or fourth, is it the fourth Thursday for the board meetings? I'd like it to add it to the last week of the month, because sometimes the Thursday starts early in the month. And then we run into this issue where the closing of the finances ends up becoming a big scramble, and it's really hard to structure that. So I was wondering if we could just move it to the last week. It ends up being that way anyway, and I think that was the intent. It's just that I would like to see if we can do that. And it does fall on that for February. It's just in the future.
So we have.
So you'll see a reoccurring invite for the last Thursday of the month, and that's what we'll put on the assembly board calendar. And then if things change at the meeting, just like regular, we can change it up, but we'll go for the last Thursday of the month henceforth.
Okay, sounds good. Do I have a motion for executive session?
Make a motion that we go into session to review.
Okay. You have to read the whole.
Executive session, discuss financial